in considering if your child is found to have myopia, then there should always be a discussion around progression control. I just don't think it's satisfactory anymore to only talk about correction and not consider what's going to be happening in the future to that person. If you're not being told about myopia control, certainly start asking those questions.
If you've got kids or know someone who does, you've probably heard by now that myopia is a condition that progressively affects children's eyesight. It leads to nearsightedness in the short term and potentially puts your child at greater risk of serious eye disease later in life. September is in fact myopia month. So today, once again, I'm with Paul Graham from Harmony Vision Care on the Gold Coast. Paul's going to discuss some of the existing treatment options, but also some of the new innovations that are happening in myopia management. So if you'd like to help your son, daughter, or a young family member to have the best vision outcomes as they grow up and their eyes develop, then this video is for you. But first, who am I? My name's Paul Salloway. I'm the owner of Optics Digital Marketing. We're an agency that assists independent eye care practitioners to grow their clinic. So hi, Paul. Good to catch up with you again.
Yeah, likewise.
So myopia month. Briefly, can you tell us what is it and what do you think is the goal?
The goal is to really increase awareness around myopia. Prevalence is certainly increasing. We see that in our practice and the mountains of research that's being done on it. And because of our knowledge of myopia, rather than just being a nuisance because you can't see clearly, if you allow myopia to get to a point where it's considered to be high myopia, so people who are sort of minus 550 and above, and what's coupled with that is that they have a much larger eyeball, well, that results in effectively the tissue in the eye not being healthy when you age, and so you're high risk of eye disease like glaucoma and macular problems and retinal detachment. And so any degree of myopia starts to increase your risks on those things, but the biggest concern is when you get up into high and very high degrees of myopia. And so if we have a look at the reasons why we think it's becoming an epidemic, then we've got to create a lot more sort of awareness from a public health point of view around what's happening to our kids.
And do you think that parents and patients have become more aware of myopia over recent years? I mean, when I was growing up, you didn't really hear much about this, but now I think there is a lot more awareness of it. Do you think that this is because of campaigns by the optometry profession, or do you think people are just noticing it more often in their lived experiences?
Yeah, look, I certainly think in there are certain pockets where there's a high level of awareness. So in certain demographics where myopia has always been for a long time a fairly prevalent part of a culture or a lifestyle, then there's a lot more understanding and knowledge around that something else can be done about it. Outside that, you certainly do hear snippets of it, but I was only thinking about it the other day that if this is driven by the lifestyle issues of not spending enough time outdoors and spending too much time inside on devices, then we need to really ramp it up to a whole level where the school environment's being changed, or timetabling and how we do things. And certainly in parts of the world like China, they've gone to great lengths to change classroom settings and how the timetables run and all the rest of it. So I think we've got a long way to go still. In Australia, we don't have the same level of prevalence as elsewhere. So it's probably from us because we have a natural outdoors lifestyle, and we're not living in as big a built environments as people in other countries. So yes, I think generally there is starting to become more awareness, but I think we've got a long way to go.
Have you noticed that parents are asking you about specific treatments earlier than before?
I have populations of parents who are on the front foot because of their own personal history. And so we're often getting kids checked as a precautionary check just to make sure everything's okay. And there are certainly families who are quite diligent at bringing kids back who, we might have one child who's becoming more myopic, but the other one isn't, but the other one is still getting regular checks because of concerns around it. We still do get, and I'm still surprised that we still get people coming in who are wearing sort of more standard corrections. And it's only that they found us that that standard correction that they started with has increased dramatically and it's worried them. And that's when they've started questioning what else can be done. So it's still a bit of a mix.
Okay. Well, that's probably a good segue to my next question, which is about some new treatments that you've introduced into your practice there. And here I'm talking about repeated low-level red light therapy. So can you tell us how that works and, what you're seeing from that and maybe, what is the clinical evidence from international studies so far?
We've probably got 2 or 3 years of really good data on it now. I think it's the devices have been around for longer than that. It takes a long time for something to
Mm,
build up momentum to eventually sort of make it to market. So basically, it's a device that you look into and it bathes the eye with a specific wavelength of red light. It's low intensity and everything that we're doing when it comes to trying to slow down myopic progression is trying to kind of change what's happening at a retinal level.
mm,
It's changes in growth hormones at the retina that seem to trigger the kind of um, increases in eye length that result in myopia and blurry sort of distance vision. And they all work in slightly different mechanisms. The exact mechanisms are still being researched. Red light therapy seems to change the metabolism and thickness of the choroid, and it's changes in the choroid which sits underneath the retina. So it's um, this pink layer here
mm,
that seems to be responsible. That's the thing that changes a lot when you first start becoming more myopic, and red light therapy seems to be changing that, which then governs how the sclera itself changes, which is
mm,
what's involved in remodeling to make the eye bigger in most cases. There's a little bit of evidence that some people using red light therapy do get a little bit of shrinking, and we're still finding out what those sort of exact numbers are. So the exact mechanism, it's doing something to the choroid to change growth. But it's a fairly simple procedure. You're looking at a red light for 3 minutes twice a day, 5 days a week is the ideal kind of compliance. Um, at the moment, because it's a relatively new treatment, we're tending to use it as an adjunct therapy, and an adjunct therapy means that someone is already in a pre-existing myopia control device using an optical device, so Ortho-K nighttime contact lenses, or they're wearing daytime myopia control multifocal soft contact lenses, or they're wearing some of these newer spectacle myopia control lenses. And they may still be getting some progression that is larger or faster than we're kind of comfortable with based on what we're trying to see where this person might end up when they're older.
mm.
And so we're using the red light as an additional therapy to kind of piggyback on top of that to try and really flatten that progression out even further.
So just to be clear, so this is not something that people necessarily do in your clinic. It's actually a device that they purchase and take home and use. Is that right?
Correct. Yeah. The one that's currently TGA approved in Australia is iRising International. You work through a practitioner who does a number of screenings, a number of sort of necessary measurements. We then talk about red light therapy on an individual basis based on their individual sort of situation.
Mhm,
And if it's deemed or agreed upon that this might be a strategy that's suitable for a person, then they then deal with iRising to trial the device, and then
mhm,
there's an ongoing sort of subscription to kind of use it.
mhm.
And it's all, and iRising sort of monitors the use of the device. So we know that people, how often they're using it. It being a red light, a low level laser, effectively, they have a lot of safety mechanisms in place in terms of making sure the device only runs for 3 minutes, making sure that you can't do it less than 4 hours apart, and then making sure you have 2 day breaks in between a 5 day sequence of treatments.
Okay. So it's not something that, somebody could just go onto Amazon and buy it. They actually have to go through a controlled consultation process with a practitioner like yourself.
Absolutely, and you need to
Yeah.
be using devices that have had a considerable amount of research and development from a safety point of view.
Right. Okay. And can you mention like some of the international work that's been done around red light therapy as it pertains to myopia?
Yeah, so the whenever we talk about myopia control, we're looking at, effectiveness. How much does this
Mm.
particular modality or protocol that you're following change how quickly your eye is getting longer compared to when they do research, they always compare it to people who are wearing just standard myopia correction. So
Mm.
if we briefly step aside and go, well, what's myopia correction? Myopia correction is purely just wearing a pair of glasses so you can see clearly again. Myopia control is doing something to try and slow down the changes in your myopia. And
Mm.
myopia management is kind of the broad base on what are we doing for a particular patient? What are all the different things that we're actually looking at to actually manage correction, manage control, those sorts of things. And so if we look at efficacy, then some of the evidence coming out is that it's quite an effective strategy for slowing progression, irrespective of what kind of correction you're currently wearing. As an adjunct therapy, it's starting to emerge on the different pre-existing lenses that we might use. Probably the strongest one that they've got so far is people who are already wearing Ortho-K. The reason they've probably got the research on Ortho-K already is Ortho-K is probably one of the longest standing myopia control strategies that we've had. I kind of almost feel like it was the one that really kick-started the whole interest in being able to slow down myopia
Mm.
sort of internationally. And interestingly enough, you've got people pre-existing Ortho-K wearers and people who have already got high myopia seem to be the ones who respond the strongest on average. Now, remember, it's a bit hard to extrapolate it to every single individual, but if you're looking at sort of population data, those early results seem to be quite impressive. So, it's just a matter of we've got to be careful that we don't have everyone thinking that every individual is going to respond the same way.
Yeah. So if I'm hearing you correctly, you're saying that sometimes using combination therapies, using like the more traditional myopia solutions, in addition to some of the newer ones, that can actually lead to like more efficacy, better results, that sort of thing.
Yeah, and what we need to remember that myopia control's been around in a version or not in terms of stronger interest in the literature probably for 10 or 15 years. It's been something that I've been interested in my practice for probably longer than that. The research into adjunct therapies is considered relatively new. It only been done for a few years. So there's certainly some signs that can be promising that if you're getting someone who needs a bit more of their control over progression compared to just what they're getting out of our sort of first line treatments, then it's certainly looking promising. But it's still a watch this space on which one's better and which one's best and how much and when should you actually present that as an option.
Right. So in your clinic, like now you're introducing red light treatments, but I think there are certain eye drops that have been popular for a while as an adjunct therapy. Do you want to talk about that?
Yeah, so atropines are both a first line treatment and can be used as an adjunct therapy. We've typically used it as an adjunct therapy for sort of co-managing a patient who's already in a more another optical first line treatment. We don't tend to use the atropine as a first line treatment because the kind of percentages that you require in terms of the concentration, when you bring that concentration down low enough that you get less of the side effects in terms of sensitivity to bright light, large pupils, those sorts of things, then the efficacy is kind of fairly similar to our other first line optical treatments, which also correct vision at the same time. So we tend to lean into, well, if we're going to have to correct your vision in order for you to see clearly, why not use a myopia control strategy? And if that's similar efficacy to medium and low dose atropine, then let's just run with that. But then, yes, our other strategies has been to then kind of refer for getting atropine at the same time if we're not kind of getting the sort of changes we're after or the lack of change that we're after.
Excellent. Well, if you're getting value from this interview so far, then please hit the like button. It's a simple thing, but it really helps other people to discover this information on the YouTube platform. All right, Paul. Well, looking ahead, so what sort of research developments excite you the most? I've been hearing some things about how practitioners are using AI to predict risk factors and like a whole range of things, whether that be glaucoma, dry eye. Is the profession also leveraging AI to assess myopia risks?
Yeah, look, and certainly I know you can see the sort of Revo behind me. I'll get my
Mm,
pointing right. That's my biometer. So that's what I measure a number of different eye measurements on for with regards to myopia in particular. We get eye length, we get corneal curvature. We're measuring the state of the macula with it. And that has algorithms in it now where you can type in how many family members have myopia, what's the current what's the person's current prescription.
mm,
We're obviously measuring eye length data in there. It's factoring in corneal curvature to and comparing it to kind of these researched risk profiles. Now, the challenge we've got is that that's not a bad starting point, and we can sort of graph changes and those sorts of things. But there's some arguments that it's not yet quite specific enough to
mm,
myopic populations to really give us really strong guidance. There's certainly very, very useful tools and so much better than what we had even just a few years ago. So yes, I think that's the space that is really going to change. It's the predicting those people who might be at risk of becoming myopic, but also kind of going, okay, is this someone that we might need to consider, a double strategy right from the word go rather than starting with something and waiting. I mean, at the moment, that's the process is, well, you are myopic, you're at medium to high risk of progressing. Let's get you into some sort of myopia control, and then we watch to see how effective that is before we start considering layering adjunct therapies because it all costs money to the patient and it's all a time basis. So we've got to sort of manage the cost and lifestyle in all of this as well. But if we can have AI starting to kind of be a lot more individual, being able to give us a lot more guidance on the individual patient, that would be fantastic. And that's where I can really see the space starting to
mm.
sort of expand.
But is that a common tool that's used in optometry practices in Australia right now, or are you sort of a little bit ahead of the curve in that field?
I think myopia is probably the one where there's enough collective interest in it that
Yeah.
there's research into it. There's the equipment manufacturers. I mean, and obviously, if there's a commercial aspect to it, then that obviously helps drive innovation. So, and in my practice, where we're dealing with lots of different kind of sort of niche things that we're sort of dealing
Yeah.
with, then that's the most obvious one for us. I probably wouldn't see it in other areas yet, but although I can imagine it happening in the dry eye space because
Yeah.
that's another area that's expanding very, very quickly and for optometrists involved in co-management of things like glaucoma, I can
Mm,
only assume that that's going to be increasing over, in optometry as well.
yeah. All right. Well, so for anyone who's hearing about, some of these new developments that are coming on stream, they might be thinking, well, is it really worth investing the money in Ortho-K or something like that right now? What's your take on this? I mean, are the traditional myopia therapies going to be with us for a while? I'm talking about Ortho-K, myopia control spectacle lenses, soft contacts. Do you think those are going to be an important part of your whole strategy for a while to go, for a while to come?
Yeah, no, and look, and if we have a look at the mix, then what that allows us to do is to customize
Yeah.
the treatment for an individual patient based on a number of different goals around that patient's lifestyle. So we can change things based on age. Are they involved in sport and activities?
Mm,
What's their ability to be able to use contact lenses and
mm,
Ortho-K?
mm,
You need to be able to see clearly. So we're always going
mm.
to have some sort of optical correction. So yes, I assume there's going to be some sort of evolution over time, but ultimately, if you're not seeing clearly, we need the first point of
Yeah.
call is we need to correct that. And so, and the other thing we need to look at is that compliance with anything in health and medicine is a really critical factor. If you need to be taking blood pressure medication or diabetes medication, you've got to be taking that every day, and your ability to manage your health condition is not going to be as good if you're not doing it. And so, any therapy that requires someone to do something day after day, day after day, sometimes the easiest things are, if we can get a pretty good result with an optical device that rewards you with clear vision, then it makes compliance so much easier.
Right.
So I certainly see that being a part of the space for a long time. And to be honest, from an evidence-based point of view, they're the ones with the longest and strongest evidence so far. So they're always going to be considered it's the one that everything gets compared back to. And so if you're making very conservative decisions, then you're going to go with the ones that have the longest level of evidence. That's
Sure.
all the optical devices that we're currently using, like Ortho-K and soft contact lenses, and the some of the DIMS and kind of whole technology in spectacles.
Right. Well, Paul, before we finished, any last thoughts for, people out there who may be thinking about myopia control and, perhaps trying some approach that they haven't thought of before?
Look, probably a couple of things come to mind is that I look at a lot of the vision problems that develop during childhood and teenage years. I kind of step back and kind of go, well, why would this develop? What problem is the body trying to adapt or to solve to? And we look at, well, what does myopia do? Myopia makes near vision sort of less stressful, because you become sort of well focused at near distances without much sort of effort. And so a big part of myopia control and myopia prevention is to make sure that you're getting outside. We really need to be, this is a lifestyle problem. Myopia is increasing in numbers because of our massive changes in our lifestyle. And it's going to require really concerted effort in families to reduce the amount of device use, reduce the amount of indoor activity, increase the amount of time you spend outside. And it really does require a concerted effort, because it's very easy to fall into the trap of being on a phone, being on a device, being indoors. And so that's probably a big one that we really need to push harder on, I think. And I think we said earlier, it would be great to see schools changing the strategy. If it's really going to be the epidemic where half the population is myopic, then we need to be doing it really at all levels. And when kids spend such a considerable part of their day at school, I mean, I think that's an opportunity for things to do.
Yeah.
And then I think the next part is that, in considering if your child is found to have myopia, then there should always be a discussion around progression control. I just don't think it's satisfactory anymore to only talk about correction and not consider what's going to be happening in the future to that person. So, if you're not being told about myopia control, certainly start asking those questions.
Okay. Well, so how can listeners get in touch with you at Harmony Vision Care?
So we've got the website, harmonyvisioncare.com.au. We've got our phone 0755205900 if you're around the Gold Coast or Northern Rivers area. And you can make bookings online through our website. We're on Facebook and Instagram as well. But in terms of getting in touch with us, the website and the phone number is the best place.
All right. And once again, don't forget to hit the like button and subscribe to the channel if you want to be notified when Paul releases more highly valuable YouTube videos like this one. And as he said, follow Paul's Facebook business page and Instagram account to see him post updates on the latest news, promotions, and events for his Varsity Lakes practice. All right, Paul. Well, thanks for connecting, and thanks everyone for watching. Have a great day, and please spread the word about Myopia Month.
And get outside.
And get outside. All right. Bye for now.
Thanks, mate.